code, so we can. Okay. Thank you so much, colleagues. So thank you so much, colleagues, for joining us today. I would like us to start the session. And we apologize for last week. We were supposed to postpone it after in our institution power was taken due to a project that was going on. But we are glad today we are here. So we would like to welcome you. And today we are going to have a good time looking around the end of life. But we'll focus a bit on symptom management. We are not going to look at all the symptoms, we'll just look at a few, and we are not going to go deeper because of the time. We'll just look on some of what can be done, really based on what we already know. So we have today a case presenter, Ngomutulu, will present the case and then we'll move straight to our didactic presentation. So for this time around, I will request her to present the case for today, and then we'll discuss around it, and then we move on to do our didactic presentation for the day.
Thank you so much, Mr. Malcolm. Like he has said, my name is Teresa Momezo, a co-shepherd student who is doing my final year on nursing assistant certificates. So I'll be presenting a case dated 9 July 2025. I'll be presenting on about a male client who is 64 years old, who is married, on prostate cancer, has prostate cancer. Fortunately, the patient is stable, hence he is on echo 0. However, the main problem that we are having today is poor adherence that makes it hard for the patient to alleviate pain. Therefore, his chief complaint was pain in the general body. We noted that he also as well complained of knees and waist pain, which is we classified the pain as electric shock-like pain and dull and burning pain, with the duration, which is, it started from with using the scale pain rate, it ranges from 6 due to chronic pain. And he indicated that the pain is constant physically. The impact of pain is moderate. So that is why the patient is on opioids, because the pain is moderate. Pain medication is partially, hence the patient, or we managed to get the vital signs for the patient when we get them to visit the patient, which is it does blood pressure of 153/1.9, which shows that it was very high with a pulse rate of 74. Temperature, which was 35 degrees Celsius, and respiratory rate is 20 beats per minute. Then we, using the pH Q9, we rated his distress, which is depression. His depression was 3, anxiety was 2. Other than that, we had no vomiting, no anorexia, no constipation. No. Therefore, however, his significant medical history. He's an HTN patient with gastric ulcer. At hospice, he was admitted on the 28th of April 2025 for prostate cancer. His past medication, he's been on HCTZ 25 milligram OD, which is he's still continuing with it. And he is also taking bicalutamide, which is the chemo, the oral chemo that she's getting 100 milligram once a day. And then he's as well taking Panadol for pain, which is 50 milligram 3 times a day. The patient managed to have to do some tests twice. He was still hospitalized, which is the FBC, LFT, tumor, maker, to this FB. And then he does have social history and family history, which is psychosocial support system, which is the patient is supposed to have full support from his second wife after being a widower. With the problems, patient reports that his major issue includes failure to acquire new land for his wife after having conflicts with children from previous marriage. So that causes him to be depressed, like you have seen on the previous slide, that our patient has depression and anxiety. However, spiritual history, our patient reports that he does pray and read the Bible, but he is no longer goes to church following the poor support from the church members. Because the church members have never visited him since he was sick. So he has just struggling to church. In the case of advanced care, we didn't discuss with the clients about the advanced care of them. But we had a further planning of care to improve quality of life of the client and family. Our plan is to arrange family meeting, because like I said, that the children, together with his second wife, they don't go alone. So we arrange a family meeting. Then we liaise with the social workers to advocate for the patient's assistance with the issue of land, because he has indicated that he has issues with getting the land for his second wife. And he hasn't done any construction but as of the building material, I've been still awaiting for the land. So we are with social workers we have in assisting to get the land, because we also stated that it is difficult to reach the chief due to conditions with Bangamani. We all know that if we need to see the chief, we have to go through the Bangamani. So he's got challenges with that. Then to maintain pain management, we added much on that one because we discovered that our patients, if you taking was not taking the pain medication accordingly, because the documentation on the medication wasn't clear for the patient. We suppose that the patient didn't misunderstand what was written on the medication, hence you couldn't take the medication according to the prescription. We gathered that our patient was only taking tramadol once a day, meaning that he wasn't taking it 3 times a day as prescribed, but he was only taking 1 dose, which I suppose that's the reason why he kept on complaining of pain. I'd like to thank you for listening. I'll wait for questions from the floor if there are any, or any additions will be gladly acceptable. I thank you.
Thank you, Lulu, for presenting the case. Actually, team, just to summarize, I can say that he has just presented the case of a made man on his older age, a 64-year-old man diagnosed with cancer. And actually, even based on the treatment, this client is on the stage 2 of the cancer. So we are hoping you will assist in terms of managing the cases for this patient. So we met this client together with our nurse, and we evaluated him. The major issues he is going through is the psychosocial issues. As far as medical-wise, he's doing well. He's stable, even though functionality-wise, we are predicting a decline on the patient, because he reported that even though he's able to move around, but he has a challenge on doing other activities at this point in time due to the prognosis. However, he is taking the oral chemo, which is doing well in harnessing the spread of the condition. But we discovered these 2 critical issues I hope Ngomutulu wanted us to work on, is the issue of adherence to medication, even though we tried something to address them in terms of education. But we wanted to bring the case in so that we can understand what is really happening with this. So we found him complaining of pain, even though he was taking tramadol. So we found that 1, he was underdosing himself as far as even with the oral chemo, because he couldn't understand the writings on the box, because he said that nothing was explained to him. For that reason, he's also experiencing these multiple sites of pain, because he has the weak opioids, but unable to take them because he couldn't understand the writing on the package or the paper or the box that the medication was kept in. For that reason, he messed up the drugs and he was constant on pain. That's one side of the issue, which was due to poor communication between him, the clinician, and then thus the medication was not effective. We are not sure how far damaged the underdosing of the chemo is gone, because he was taking half of what he was supposed to take. And then we have the issue that is so pending now, that every time we're talking with him, we keep on rotating around the issue of finding a place for the second wife. So we don't know what's the best approach. Even though the case was handed over to the social worker, but we don't know what is the best approach that can be taken, because there are these chief counsel delays and up and about he reported about. And he said that even the wife has been taken down when he was approaching. So we don't know. How best can this case be held? Because that delays and frustration and the wish to secure a land to build for the wife so he can be taken away from the children who might be fighting for their mother's property at this point in time. So we felt that the core goal and desires of the patient now is to build that home. Unfortunately, the material is rotting there. So we brought this case to the team. Maybe they can advise the team to say, okay, in such a case, what could be the best approach to address such a matter? Thank you so much, team. Maybe someone may want to share. Yes, if someone wants to share, we can appreciate. We can appreciate. If someone could have a solution on this one. I'm trying to look for anyone at the end, how best we can deal with this issue. Anyone who can help. What could be your suggestion? What can the team do? I think in our team we have the social workers. They can know even what can be done in this case. So I hope they are also going to enjoy getting to know that in such a profession. Because then the patient priority now, even though the treatment, but the major one, it's finding the space. So what could be the protocol? Because it's like he feels rejected by the chief counsel. And that one makes him more sick than before. Actually, even mentioned that doctor said he must address the psychological, psychosocial issues for him to cope well with the treatment. So now he feels under pressure. So what can be the solution, team? Maybe if you have something to suggest, maybe we can appreciate that one. I'm looking for hands. What would be your advice? If this was your case, how would you address such? And it's our feeling that maybe if the patient can achieve this goal, he may then have rest. Possible can allow himself to go. But unfortunately, the journey is not possible with this. Oh, Margaret needs a committee to explain the issue of, is the man widowed? I missed the link between the wife, children, and the baby. Please explain.
Oh, thank you so much, Namita. The man is widowed, but he eventually took a second wife. With the children, for the first wife, they are not supporting him. They are not there for him. He is only survived by the second wife. In actual fact, they just don't want him to have another wife. So they are not supporting it for. Hence, the patient even indicated that when they were trying to plow, they just stopped the second wife from plowing the fields. That is why he is looking for another land to build for his second wife. Though they have children together, but they are still minors. That is why he's suffering depression, because he wants to secure the land for the second wife and the young ones. Thank you.
I hope we have got the response concerning the leadership and the wife and the children and the yeah.
Thank you, Tim. I was trying to think, so now I can think aligned. Thank you for the presentation and the case. To me, it's quite complex because as she's explaining now, I can understand that it is beyond him. The children also need to be attended because they are part of the family, even though their mother is no longer there. Yes, Baby has found love. He's got another wife. But for them to allow their father to go, it's a different story. Even to accept Mage Lomnane, even if she was there before their mother passed away, they also need to be attended to. And Baby needs to appreciate the bond the children have with him, even now that he has another wife. And we may never even understand the complex issues around the chief's council not giving him land for this new wife, because there could be other issues behind what the team has been told. So it does need some patience, proper research behind before we can even say want to engage the council or call the family meeting. I wish you could get some key information somewhere, 1, 2, 3, 4 around the family, around the community, so that you can get the appropriate approach to this issue than maybe to be seen assisting someone just because he wishes this, yet there are other issues that needs to be addressed. I do agree that he needs help, but I think you need more information in order to approach this issue in a more sensitive way, in a more appropriate way, and even culturally appropriate way. Otherwise, thank you for sharing.
Thank you, brother. Thank you. I hope they are not you do the handover very well. Yes, anyone else who may want to enter or comment? Okay. Maybe without the show of hands, I will just say from the symptomatic side of the patient, there are things I learned from this case, which I feel like we need to take it serious as clinicians. The issue of clear communications and medication instructions. Because I don't know the impact of taking the half dose of chemo, how much damage it has done to the patient, because he has been taking it for some time, but not taking it as he was supposed to, just because of fragmented communication. And I hope the Manzini Hospital will be here so they can get an understanding of this, because this is a case from their facility. So I don't know, we need an interdisciplinary, and I hope we could have pharmacists joining us so they can understand the implication of halfway communication, especially to these elderly people. Because really, if it was communicated to him, he will take the medication as appropriate it could be, but halfway communication. And one of the messages that he said again, sometimes they will say 3 times a day, and the patient will not understand when they say in the morning, in the noon, in the afternoon, he doesn't understand anything. And actually, medically, it doesn't make anything. So I don't know how we can emphasize the issues of giving medication on time, other than just stating periods. Because what is happening with this old man, he couldn't interpret the 3 times a day. He couldn't understand. To him, 3 times was like 1 day, because he was taking the drug once a day in the evening. Because one of the drugs, the chemo one, was supposed to be taken once a day, and was taking it in the evening. For that reason, he was having this excruciating pain. So just because the pharmacist couldn't tell him, and he began to, when we were explaining, he then regretted what the pharmacist told him. He said, you know, you clinicians, if you could communicate like you are saying it now, I will be better than before. And then I was like, wow, this is one of the things we miss when we are talking with them. We like to digest the information until it makes no sense to them. The best way, let's give them the pure information and then let them say, I don't understand. And then we break it a little bit down, and then we ask them if they understand what they're saying. But sometimes you'll find that the prescribing nurse or clinician in the consultation room will explain, but then on dispense, you find that the gaps comes in. Look at it, we were supposed to travel very fast to this patient as an emergency of pain control, only to find that the drugs we are bringing to him are the drugs that he has. It's just that the information issue resulted to an emergent issue of pain control, which was to be avoided. And failure to do that communication, it has a lot of cost implications to him, to the clinician team, and the country at its best. And then, because now there are chemo drugs he's taking, and he's not taking them as necessarily he should. When he returns back to for review, he will be found not progressing well with the treatment. And the country has spent more money to buy the medication that has now been flushed through the drain, and then he will be given another one, and then later we will come as clinician and say, there are no drugs. We wasted them through communication. So that's what I learned. I said, you know what? One of the drugs we have that are not perishing at any point in time, correctly used, is communication. So as clinicians, let's embrace communicating the medication order very well to the clinician, and educating them how to take them will save us money, time, and then save the patient's lives. So that's what I learned from this case. Indeed, this is not just theoretical. Communication is the backbone of palliative care. Without communication, actually, communication is the backbone of healthcare. Without clear communication, there's no nursing, no medicine, no whatever. There is no care. So that's what I learned. If we can learn it, then we can do it. And then through practicing and learning it, learn to communicate, learn to communicate. Actually, teamwork, putting the client into the team and communicating the message clear across the whole stakeholders or team members is more efficient and more effective in symptom control and improving the quality of life. But today I want us to look brush through the symptom management. So let me go straight to the presentation so we can have time and see what is there. I don't know, maybe sometimes I will be cutting out. My network is playing games with me, so I don't know what is happening. So please bear with me. I want to find something. Let me try this one. Let me try this one. So I want us to go through this presentation, and then we'll be out very soon. So I want us to see a summary of this. Wait a bit, it's coming. I have a go slow of network, but it's coming. It's coming. So bear with me. Now I'm told you can see my presentation. So I want us today to just go through symptom management. It's the same we've been doing before, but I will be focusing closer to how we can approach this at the end of life. We have discovered at the end of life, at this point in time, the patient is approaching the end. So now we are looking at providing comfort and dignity to this patient. So we'll look across a few principles. So we will try to outline the core principles and the best practices for managing symptoms at end of life stage. And then we'll focus more on the common interventions for end of life symptoms. So I will not go on the most, but I will just look at the common, what is common there. We will also examine the implications of surgical medical interventions at the end of life, because that's one of the things which may include the artificial inhalation interventions. So we'll look at those implications. Many of the times in my 8-year experience in palliative, it's the age of 7, I don't know. In my years in palliative care, I've got immediate calls from colleagues. Hey, we have an issue. My parents or a so-and-so's relative is no longer eating. Is there anything hospice can do for this client? I've been getting those messages. And normally I will say, oh, okay, no, if you're not eating, don't feed. I will see tomorrow. But by tomorrow in the morning, I get another call. Oh, now our relative has passed on. And it has happened many times in my experience in care. So for that reason, I hope I will share those experiences while I'm going through this presentation with you. So there are principles we need to understand when we are managing symptoms. These principles, they apply across the whole spectrums of care. Whether it's pain, but as long as you are dealing with the patient, we need to understand the principles. So one of the principles is that there is a temptation when we are approaching the end of life, that as clinicians, remember these principles, I'm talking about people with terminal illness approaching the end. Death is something imminent. There's nothing you can do to reverse it at this point in time. The only thing you can do is to shorten the journey and remove the bumps along the journey for this patient to go to die peacefully with dignity and in comfort. So there is a temptation across the clinicians, across the levels of care, to have a magic, a miracle to happen with these patients. For that reason, they become these dummies we had when we were doing nursing school. They become our test ground, whereby we now want to have a miracle intervention to reverse death. One of the principles of palliative care is that death is a normal process. We are not enemies of death, but we are enemies of, we are friends of a good life. We cannot change death, but we can affect the journey if death is going to happen as a natural process. So I want us to understand that the principles that can help us promote comfort and manage symptoms when we are taking care of these patients. So one of the things we need to understand is that whatever intervention you are going to establish at end of life for these patients. It must be patient-centered. What does that mean? In our previous presentations, I talked about advanced care planning, knowing the patient wishes. We talked about ethics, knowing the ethical principles when we are providing palliative care to these sometimes incapacitated patients. So it is very important to have ACPs because of any time you are going to provide care for a patient approaching end of life or in end of life. It needs to be patient-centered, regardless of the patient's functional status, cognitive level, palliative care phase, regardless of whatever the status of the patient, it must be patient-centered. So the care or intervention should be tailored around the individual ACPs, which the advanced care plan wishes must be put into concept whenever you are setting up those goals. So this is when we begin to fight with the families, because now we need to look at the patient's or the individual's preferences, values, goals, to ensure that the patient autonomy is not tampered with until the last breath, actually, until the body is buried on the ground or in the ground is buried. So that's one thing we need to understand, that anytime you are going to do an intervention to a patient at the end of life, ask yourself, are these interventions at the preference of the patient? What are the values of my patient? What does this patient value the most? What are the goals of this care? For that reason, in palliative care, we have this process called goals discussion. So if a clinician has missed the opportunity to have what we call goals discussion and ACP discussion, you will have a crisis intervention at the end of life. Because now you will have to balance ethics and the family preferences over the individual's values, wishes at that point in time. So this is the first principle. The reason that we encourage ACP discussion when the patient is stable is because we know that when you are diagnosed with a life-limiting condition, you will reach this stage whereby all those tools as clinicians, we will need them on board to ensure that patient's autonomy is maintained and comfort and peace is maintained. All right? This is principle number one. Principle number two, as a clinician, we need to understand that we need to be good in assessment. And good assessment will help us to be proactive in our intervention. So what does it mean? We need to early identify the stage itself. We need to early identify clients who are approaching the end. One of the diagnoses of a patient approaching end is the frequency of admissions to hospital. And a patient that will come in 6 months has been admitted 3 times. For it will approach the emergency room 3 times for the same problem. We know that understanding the disease trajectories that we have discussed before, it will help you identify these patients who are approaching the end. So the proactive and routine assessment of symptoms at end of life is very important, because that one will enable us to be proactive in prevention. We know palliative care by nature is preventative. So we will prevent the suffering as early as possible, and we will put interventions timely and be on time when we are intervening. And we will help the families to be equipped to know what to expect and combine that one together with the patient-centeredness, all right? Another thing we need to understand is that another principle, when the patient is approaching the end, like this one we're talking about, it requires a multidisciplinary approach. My government has said, you know what, guys, let's do an in-depth investigation and engage the other stakeholders involved in this patient. So that reason is why we need collaboration when we are dealing with this. The families need to be put on board. The clinicians need to be put on board. Everybody must go in place, because sometimes a doctor needs to move a little bit back, and the lawyer must come in front. Sometimes the nurse needs to go a little bit back, and the social worker will come in front. Why? It depends on the needs of the patient, and then we know who in the team must come first. Sometimes the family in front and the clinician at the back. So we need to engage the interdisciplinary team and keep each other on board. So interdisciplinary approach. And one man show will push the clinician or any of the team members into what we call an intensive grief. Sometimes it can be very complicated because it will be combined with burnout and stress. So we need to have the interdisciplinary because it becomes a therapy for the team and the patient. Another issue we need to know is where good. Why is it good? We need also to understand that we need to know the balance between a relief and respect. The critical thing here is the patient's dignity. We don't want that the patient now is approaching the end, and sometimes this confusion may not make decisions, and then we turn them to animals even further down below an animal to nobody else. Sometimes we prescribe interventions that will relieve the symptoms, but not prioritizing the patient's right to make the informed decisions. So we need to have these. The patients must be at the center of everything. So we need to embrace comprehensive assessment. You check, evaluate, active. You check, you evaluate, you know what you call the PDC cycle. You know, you plan, you plan, you do, you check, you plan, you do, you check, you plan, you do, you check. So that's what we need to do. Comprehensive assessment and monitoring at this point in time is very important. There are validated tools that we can use for symptom management. They are there. It's for each and every institute to adapt which tools to use, which system, which documentation system will guide us to be sure that we are comprehensive in our assessment. So we can assess the patient in all the 4 dimensions: spiritual, social, psychological, and physical. So we can understand that we are moving with the clients in a holistic way. So one of the things we can use is we have these validated tools. Even though the research nationally is not that much in validating some of the tools. For example, the 5-finger pain assessment tool is not yet validated in Eswatini. So we need some studies to validate the 5-finger. How valid it is, how effective can it be? Can it give us the accurate results now? So we also need to embrace regular assessment, regular, put it into play. And then as the condition evolves at the end of life, we need to also regular follow-ups. Now certificates evolved from physical contact only, we also need to embrace technology on that. So sometimes you will need to do some evaluation or regular assessment through sometimes telemedicine or telehealth. So we need to embrace it, but it must be regular. So you need to follow up. If you have put up interventions, follow up soon, because these patients sometimes they move to deteriorating and terminal. So there's a lot of changes happening with them. Another thing is that the honoring of goals, documenting and respecting patient expressed wishes and goals of care is very important. Even though it comes with the dilemma of fighting with the families, but it needs to be honored and needs to be done. The last thing that is very difficult to do in care, and is the very most important thing, open communication. It's very key. Maintaining a transparent, empathetic dialogue with the patient and their families. Telling them the truth, non-brutal way, but telling the truth. Telling the truth, embracing humanity, empathetic, but telling the truth, but not in a brutal way. It's very important. So that they journey with you. What I've experienced that when the families sometimes are told the bad news of end of life and death, because when we're talking about the D word, we need to mention the D word, death. We don't need to cover it now, state it well, but not in a brutal way. But open communication helps, telling them the truth so they can make the decision. I usually ask a question when I'm doing trainings. If you are going to die tomorrow and You are not told. You will be robbed of greater things. But what something that is so different that you wish to do? And many of my audience or students, I will say so, have always said, I would appreciate to be told if I was going to die, because that will enable me to change my ACPs, to change my goals, to focus what matters most. Let's not wrong there. Open communication. Sometimes it's very painful. Sometimes it's not easy, but it must be talked. It must be discussed. So pain management is one of the symptoms we are dealing with at the end of life. So one and the best treatment that we need to work for is the opioids. In our previous presentation in the past years, we have dealt around opioids and pain management. So I will not deal much of it, but I will say primary treatment of moderate to severe pain with careful titrating and monitoring, we need to use opioids. Actually, tramadol, I would say, has some limitations because of the pharmacokinetics and its metabolism and stuff. It has to go through. So it's not the best. Codeine is not the best. I don't want to mention the issue of fixed dose combination because that is the way the NN we have. Responsible as we can. Otherwise, we need the pure drugs, not the fixed dose combination drugs, because they are hard to manage. But having the opioids, they help even dealing with other symptoms. For example, when your patient has breathlessness, opioids will help. So these are the best drugs we have, and they are easy titrated, especially liquid morphine or morphine. Having it both the long release and the short release of it. It works very well. So if it's available, that's why it's the best. Adjuvant medication, sometimes with this patient, they undergo certain phases. You will need some drugs that will support these opioids. So we can have your NSAIDs there. We can have your anticonvulsants. They help complement opioid therapy. Especially NSAIDs will be hit when there's inflammatory, when there's bone-related pain. Sometimes adding the NSAIDs will help deal with bone-related pain. And then the anticonvulsants, when the patient are approaching the death, sometimes they go through those phases. So helping them, especially when they are dealing with neuropathic pain and other pain, it helps to have those adjuvants with them. There's what we call palliative care just in case box medication, just in case. It's an extreme level of it, but if it's done well, it helps relieve symptoms and reduce hospital visits to relieve certain medication. So we have a just in case box for them. And then we also use the non-pharmacologics medications. Even though they are not solely alone used, they complement the drugs. So we need to have the non-pharmacological. And using non-pharmacological medications, they need to be patient-centered. Find out what works for the patient. And then it's when you do what we call strengths and weakness assessment, and then you are able to come up with the best non-pharmacological assessment. You say what? Yes, so yeah. As kids, I'm seeing a comment. I want to see what it's all about. Yeah, okay. And then another thing I want to understand that another symptom, another problem that we have it's managing breathlessness. It's another common symptom. So these are the common ones. So dyspnea is one of the problems. And look at this. When we are managing dyspnea, what are we going to give? Lower dose of morphine. So that's why I'm saying lower dose of the opioids will help you deal with this. So having them next to our patient is good, but sometimes the supply chain of it is not looking good. That's not sometimes beyond our control. It's for the system to work on it, but it helps relieve suffering. So if you have it as a just in case box, then you find that your patients are able to cope and do better. And sometimes having those supportive therapies, sometimes having a fan, oxygen for hypoxic patients, it also helps. And also another issue is that when we are dealing with what we call symptom control, we need to deal with the root cause. So if the root cause is a reversible problem, it's best to focus on the root cause and then reverse it. But then if it's a non-reversible cause, you need to palliate it. All right? So if it's fluid access, we need to deal with it. If it's infection, data. But the key issue is deal with the reversible factors that are contributing to the dyspnea. Is the best thing to do. But if it's the non-reversible factor, then palliate and allay anxieties and provide comfort as possible as you can. And then the comfort measures, being there, being available, talking with the patient. Okay. All right. Another issue we need to understand is that there are other GI symptom management or problems. There's one called symptom control. One symptom control, like constipation, as long as there's an opioid prescribed, it must be anticipated, it is always there. So we need to provide stimulant and stool softness so that it relieves the discomfort caused by constipation. So our stimulant laxatives include bisacodyl or Senna, and then we can have our stool softeners like liquid paraffin, or we can try also others like lactose. And then we also have nausea. It's one of the things that is common because when the patient is approaching the end, the gastric motility we know goes down because the patient is dying. Sometimes it can go up, it can go down. So in fact, that gastric motility. So you need to know what drugs we can give, like ortenastrone can help, haloperidol can help. But what is very key in managing these symptoms, like especially nausea, is knowing the root cause. What is the root cause? Because nausea is one of the complicated symptoms. You need to know what could be the cause of that symptom. And then another very important issue is that when you're approaching the end, one of the common things that happens is mouth care problems. So we need to focus on the mouth. I usually advise when I say, oh, my child is not eating. No, you know what? Sometimes less or none is preferable when they're approaching the end. But encouraging mouth care, get the toothbrush, get the water, let the mouth be clean. Let the mouth be clean. That's the best gift you can give them. So it's very important. And then sometimes they go through bowel obstruction. So sometimes we can consider HG tubes. In some cases, sometimes spasmodics are used or are beneficial to the patient. All right, that's under bowels. I don't know, managing sometimes freezing. I don't know what we are fighting for with it. Okay. Another problem we need to look at it's wait, where are we now? Where are we? What is it doing? There's a slide that needs to be here. Oh. I'm in a game now. So another issue that is more common is delirium and terminal agitation. So this is one of the problems, and it's more frustrating. And the family members, they go through trauma when this one happens. And sometimes they will get an emergency, go straight to hospital. Sometimes they will get loose and don't know what to do. Also, identifying the cause of this is very key. So it's only through assessment that you will find what could be the cause. And once you have found the cause, ascertain if this is a reversible cause or non-reversible cause, because you can't put your clients under trauma just because you want to deal with this delirium or agitation. No, you need to know what is the contributing factor to this one. Is it a reversible one or not? Sometimes they will use antipsychotics like haloperidol. They can use to deal with distressing agitation problems, so they can deal with that one effectively. Non-pharmacologically, creating a quiet environment and encouraging family presence to help the patient calm. Because think of it, the patient is now seeing that it's detaching his physical world and going to unknown space, and then agitation will take place. So we need to have the family's presence here. For that reason, one of the key weapons we have in palliative care is just presence, your presence. So educating the families, just being present, holding the hand with the patient. If it does traumatic, but it's soothing to the patient. Okay? This is one of the things I've seen when I was in the ward, is restraint. Once the patient goes to agitation, we take him to restraint. This is not okay. And for the patient who's end of life, this is not okay. Families will do this, they will change the patient. This is not okay. If ever it should be done, let it be the last of the last results we can ever think about. And it must be client-centered, not clinician discretion-centered. Must be, and the patient must benefit, the patient must benefit from it. It must be the patient's well-being. So let's not educate the patient to do that. And then we have also another dilemma or problem when we are approaching the end. Who has unmuted his mic? Zakayo. What are you saying, sir? Oh, now you're silent. Thank you. All right. So another issue we need to understand as clinicians is that we will always find ourselves in the dilemma of artificial feeding and hydration. We will find ourselves under pressure from families to administer artificial feeding and hydration. I've done a few readings on these two. I discovered that this was initially meant for post-operation, not for dying patients. No, this was not meant for patients who are dying or who are at the end of life, who are approaching the end of life. This was not meant for them. It was meant for post-operation. But then we need to know this. This is what I found. You can go there and read it for yourselves. The benefits at the end of life. This is what I found, literature on palliative care and these two. And please, if you want to avoid the pressures from families to do this, do education proactively. Educate them about end of life. And include this one, that artificial hydration and feeding has limited benefits at end of life. There are more problems than the benefits. So actually, it doesn't help them at advanced stage of life. And most of the time, families will request these two interventions when the patient is really now at this advanced stage of end of life. So let's educate them so they can understand it is okay for the family, the patient not to eat when they are at the end of life. All right. There are more complications. Look at this, risk of aspiration. How would you be when the patient will aspirate and die in your hands? Risk of fluid overflooding. There's overloading, and then the patient will develop what we call heart problems and bed sores because of fluid overload. Increased secretions, adding to discomfort, all this. You were intending to help, but actually at end of life, you are pushing the patient deep into discomfort, which is contrary to the purpose of palliative care for the patients. Number 3, patient goals. You need to check, should this be given? Does it align with my patient wishes and expected benefits? Not just the clinical possibility that it can have. We need to evaluate it against the patient goals. So at this point, unfortunately, the patients are unable to talk. For that reason, having ACPs on these interventions is very key because it helps us to know what to do. Remember, when the patient cannot talk, you have the ethics and good clinical practice guidelines to guide you what to do at this point in time. More especially, we have the platinum rule to govern us at this point in time. And then another thing that is very important at this point in time is clear communication. It helps allay the anxieties, relieve the pressure, sit them down, take them through the process, and educate them on this one. Okay? Be honest and be open with the families. And when you are educating them about this intervention, agree with them that no, I understand that there are benefits you are looking for, but let's look at the benefits and the risk at this point in time. And together, put the patient in our priority list. All right. Ethical and communication consideration at end of life. I will not detail much on this. I've been talking about them again and again and again. And I will just say ACPs, 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 ACPs. Why? They will empower the individuals, clients, and families to make what we call informed decisions and choices regarding current and future care. ACPs, 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 ACPs. Please sit down with them. Let's discuss. You know what? I'm assuming and closer to understanding it. Most of the time, we shy away from ACPs because we are not comfortable about discussing these uncomfortable discussions. At that point, at the expense of the patient's comfort. Let's go back to patient-centeredness. Honest discussion, honest, or the transparent conversations about prognosis. You as a clinician, I have presented to you two tools that are very important to know: the disease trajectories and palliative care functions, and the functional status. Actually, there are three. Is the functional status, is the palliative care phase, is the disease trajectory. To help you in anticipating and diagnosing the prognosis of the patient. So please, have transparent conversations with the patient about the prognosis. You are seeing the patient by plotting the functional system is not going up, it's going down. Why are you not being transparent and honest and discuss your findings with them? Please, let's do that. It will help us at the end of life. Cultural and religious sensitivity is very key. So we need to respect the patient, diversity, understand spiritual preferences, all right? It's very important to be integrated into the plan, because in Eswatini, I've discovered that even though we have 1.1 million Christians, I will say, please sit down and understand the diversity in the spirituality of the patient. Other than the religion of the patient, focus most on their spirituality dimensions. It's very important. Are you still guys seeing me? I'm lost. I don't know. All right. I think you still see me. I can still see something blinking. So another issue is the family support. Let's not be the families to support the patient. It's very important. On some areas across this presentation, I would like to say, let's help one another. Let's watch another. Let's collaborate. Let's engage one another. Let's engage the other professions that will help us deal with this. And let's engage on careful decisions, especially when it comes to artificial feeding and hydration. We need to put the patient at the center in our deliberations and discussions and prioritizing comfort. Individualized care, ongoing assessment, and personalized comfort are very critical at end of life. Number three, I would say, to everything, let's put quality of life ahead. Let everything center around quality of life. And understand that symptom management is the cornerstone of quality of end of life care. So let's do that for our patient. So I would say those are the things I can share as far as symptom control is concerned. Otherwise, thank you.